Welcome to episode number 27 of Reimbursement Readiness, Business Tips for Wound Practice, presented by Kathleen and friends. As you know, my reimbursement friends and I are always willing to discuss reimbursement-related topics that you, our valued listeners, request. Because so many wound and ulcer management professionals are failing payer audits due to a lack of documented medical necessity. Many listeners have requested us to provide specific documentation that payers expect to find during audits. So in response to those requests, I invited Donna Cartwright to provide a series of audit readiness podcasts. Donna is the owner of a small consulting firm that specializes in auditing, education, and documentation. She conducts friendly internal audits of physicians and other qualified healthcare professionals' practice records to ensure that their practices are ready for audits, such as UPIC, TPE, OIG, commercial payer, and others. The audit series has two goals. The first goal is to review the different parts of the medical record. And the second goal is to describe what many auditors look for when they request your documentation. Now, part one of the audit series was released on July 23rd, 2026, in episode number 25. If you missed part one, I highly recommend that you take a few minutes to listen to that informative podcast in which Donna addressed documentation of the pertinent history and physical. Now, today, in part two of the Wound and Ulcer Management Audit Readiness series, Donna is going to share valuable information pertaining to documentation of wound and ulcer descriptions and measurements. Welcome, Donna.
Thank you, Kathleen. It's great to be back talking to our listeners regarding audit readiness. Today, we're going to discuss the importance of accurate measurements, as well as complete wound descriptions that should be documented in your medical record. Both are essential to making a case for medical necessity of work performed at every encounter. So first, we'll talk about measurements. You need to measure the wound with digital technology if possible. Do not use ruler measurements because they are not consistent. Many times auditors have cited that the ruler can be inconsistent and the measurements are different even using the same ruler. So digital technology is best if you can. Report wound measurements in square centimeters, length times width plus depth. Note, you have to only use length times width when you're selecting the code for application for cellular and/or tissue-based products for skin wounds or CTPs. Only consider the length times the width. Document the original measurements of each wound at the first encounter when the standard of care is provided. This defines the start date of each wound and begins tracking the wound's progression over time. Oftentimes, in subsequent encounters, that fact gets lost, and auditors often question how long has the patient had the wound. So that will certainly answer their question. Document the complete wound assessment, including the measurement of each wound at all follow-up encounters. And document the measurement of each wound following any procedures, such as debridement, application of CTPs, application of autologous blood-derived products, compression, and so forth. When you are documenting wound measurements, always discuss the changes in wound size since the last encounter, meaning is it larger, is it wider, smaller, longer? So that gives the reader and assessment of the progression of the wound. Measurements should be taken at the end of 4-week standard of care. This helps to explain the effectiveness of the standard of care therapy that was chosen by the provider. It is anticipated that wounds will reduce in size following treatment. Measurements in the medical record should be demonstrating this. An increase in wound size may indicate that the treatment should be modified. If advanced therapies are utilized for chronic ulcers, the size of the product selected should be based on the size of the ulcer. Accurate measurements assist in the telling of the story of each wound or ulcer and help justify medical necessity for subsequent treatment and provide medical necessity for a treatment to be changed or discontinued. Photos at each encounter visually document the improvements in wound size or areas of concern. Many charts that I have reviewed do not contain photos. So if you do have photos and they're in separate files in your medical record, you should actually print them out along with the record so that the auditor is able to see those photos. So let's talk a minute about wound descriptions. Wound descriptions other than the measurements for each wound should include the anatomic location or locations for each wound. Is the wound a recurrent site? Is this an ulcer that has healed and recurred? Description of a previously treated area, such as graft take, infected, progressing as planned, etc. The percent epithelialization, the percent slough, fibrin, necrotic tissue, any odor, drainage type, purulent, serous, green, etc., and amount, none, minimal, moderate, heavy, extra heavy. Peri-wound descriptions and percent healed of each wound. Be sure to include viable skin and or scar if that is part of the description of the wound. That's very important. Document if the wound is acute in origin, and acute meaning abrasions, bites, lacerations, open traumatic or surgical wounds, burns, open fractures, Mohs, complication of surgery or medical procedures. Acute wounds are caused by external forces, and they'll usually be found in the trauma chapter of ICD-10. Document if the wound is chronic, for example, diabetic foot ulcer, vascular ulcer, or pressure ulcer. Also, document any underlying cause, such as diabetes, vascular disease, lymphedema, inflammation, or other chronic conditions when you are describing the origin. That plays an important part in deciding which codes to utilize in describing the case. So let's talk a little bit about description of treatment results. This is the number one thing that auditors find lacking in the documentation because each encounter is its own separate entity. So it's very important to document the results of any previous treatment provided and the impact on the measurement of each wound. Again, whether it's smaller, larger, no change, and so forth. Document any partial results. For example, if there's improvement in peri-wound, the odor, shape as improvements. Sometimes treatments may improve part of a wound and not others. Note any anticipation of healing rates based on the underlying conditions and therapies used. Be sure that the predictions match the stated measurements and appearance as you have described in the medical record. Anticipated results should explain the rationale for the treatment selection and the anticipated impact on the wound, such as reducing exudate, accelerated healing, the healing process, prevent infection, close the wound, reduce edema, and so forth. So some of the reasons for claim denials and repayments after audits, I wanted to call to your attention in terms of measurements. Failure to demonstrate any progress in the wound with the treatment utilized. That's often a reason for denial of a case. Continued treatment with the same method when the wound is not responding to treatment. Medicare does not pay for things that are not working. CTP square centimeters are too large or too small to cover the wound. The percent type of tissue does not equal 100. This may sound simple, but I find this often when you're looking at a wound description that it doesn't equal 100. So example, 50% epithelialization, 30% granulation documented, but there's nothing said about the other 20%. So is it healed skin? Is it scar? What is the other 20%? Whatever it may be. Missing measurement after treatment provided. A lot of times when a procedure or any kind of treatment has been provided, missing measurement after treatment is the one that's missing, and that helps to demonstrate the effectiveness of the treatment. The depth included in calculation of the square centimeters for total surface area for coding purposes of procedures. Again, you don't use the depth in calculating of square centimeters for total surface area. As you know, CPT describes the square centimeters in length times width for coding purposes. Incorrect square centimeters recorded for the size of the product used. Sometimes on manufacturer's website, they will have a conversion for you so that you know the exact square centimeters per product size. And billing for any wasted CTP not used on the wound. And again, that's a recent change, but again, I call your attention that they will only pay for the CTP that is used in the wound. They do not pay for any wastage. So other reasons for claim denials and repayments after audits, we'll talk about the wound descriptions. Missing documentation that the wound is infection-free, especially when CTPs are used. So it's very important because most CTPs are contraindicated in the presence of infection. Sometimes there's a mismatch between wound descriptions and other documentation in the record. So for example, wound improved, but the measurements do not reflect the improvement. And as I said, it could be other things that improved other than the measurement. Missing documentation that signifies the results of each treatment and its effectiveness. That's usually every visit. What did you do last visit? How is it working? And what are you doing this visit? Missing the 4 weeks of documentation of specific standards of care provided and by whom. The results of the standard of care therapy often justify the advanced therapy chosen. Inconsistent documentation of percent epithelialization, granulation, slough, fibrin, necrotic tissue that do not add up to 100, as we talked about before. Lack of documentation that evaluates the performance of a specific therapy week over week. So if you're using a VAC or you're using a hyperbarics, whatever it may be, you need to document what that performance is for that specific therapy. Missing documentation of the wound descriptions for each wound. Be sure to indicate if a wound is closed. Otherwise, there is a question as to why the wound disappeared. So example, you have wound 1, 2, 3, 4, 5, and the next visit you only have 1, 2, 4, and 5. Just be sure to document that number 3 closed. The missing origin of each wound. Oftentimes, the wound will be mentioned, but it will not say the origin, and it will not designate whether it's acute or chronic, as we talked about on previous slides. So I've prepared a checklist that you can use for your internal friendly audits. And I tend to use this type of checklist when I'm reviewing records. Use the checklist to evaluate the wound measurements and wound descriptions in your own medical records. If those items are not documented, make immediate plans to improve all the deficiencies. Improvement plans could include internal education and refinement of the electronic health record that you're using to capture all the required wound ulcer measurements and accurate wound or ulcer descriptions at each encounter. Thank you for listening to our audit readiness series. I hope you will join me for part 3.
Well, thank you, Donna. Now our listeners should understand the importance of accurately measuring wounds or ulcers at each encounter and after every procedure, and of documenting the change in size since the last encounter. They should also better understand the importance of accurately describing the wound or ulcer as well as its origin. This information is vital to painting the picture of the wound or ulcer, to supporting the medical necessity of the work performed at that encounter, and to passing pre- and post-payment audits. We will be looking forward to part 3 of your audit readiness series, which will discuss wound and ulcer management care plans and progress notes. Now, as always, I am encouraging all listeners to keep sending any topics that you would like the reimbursement readiness team to cover and or questions that you would like us to answer. You can send them to my email address, which is kathleendSchaum@gmail.com. Once again, thank you, Donna, and thank you to our loyal listeners. Without you, reimbursement readiness would have no purpose. The entire reimbursement readiness team values your opinion of each episode. Therefore, we would appreciate if you will please take a few minutes to evaluate today's episode. You can easily do that by clicking on the QR code. Now, if you find these reimbursement readiness episodes helpful to your business, please invite your clinical colleagues and your revenue cycle team members to subscribe. Everyone is welcome to learn with us. Now, stay tuned for our next episode where we'll explore more strategies to improve your wound or ulcer management operations and reimbursement. Until then, keep doing the right thing for your patients and for your business. I look forward to talking to you again in 2 weeks. Thank you.